Country SAPHN would like to acknowledge the traditional custodians of the lands across Australia and pay respects to the elders, past, present and future. We recognise and respect the unique cultural and spiritual relationship to the land, waters and seas, which continue to be important to Aboriginal and Torres Strait Islander people living today. Country SAPHN extends a warm welcome to everyone joining us today for this Triage in General Practice webinar. My name is Jane Williams and I work as a Practice Support Officer at Country SAPHN. My experience includes over 40 years as a practice manager and working as an accreditation co-surveyor in general practice with over 900 visits across Australia. The objectives for this webinar are to acknowledge the need for a structured and consistent triage system, to explore the team approach required for safe and effective triage, and to understand the importance of timely communication and documentation throughout the triage process. The current shortage of GPs in regional areas and related staff turnover in general practice means longer wait times for appointments. This puts more pressure on administration staff to prioritise the order in which patients are seen, know when to re-perform triage if the patient's symptoms worsen, and when to refer to doctors and nurses for clinical decision-making. A structured and consistent triage system that is aligned with the current RACGP standards helps the practice meet accreditation requirements. Non-clinical reception staff are the first point of contact for patients phoning the practice for an appointment. Clearly, defined roles and responsibility within a whole team approach ensures safe and effective triaging in determining who needs immediate care, who receives an appointment that day, and who can wait for an appointment for up to 24 hours. Participants will explore the critical role that reception plays in ensuring that the right patients are seen at the right time. So what is triage and why is it important in general practice? The process of triage was first described in a manual of French military medical care in 1792, when the French word trier, meaning to separate, sort, shift, or select, was applied by a French surgeon in the Napoleonic Wars. The wounded were sorted according to the severity of their injuries into dangerously wounded, less dangerously wounded, and slightly wounded. Injured soldiers were treated, regardless of their rank or nationality, according to the urgency of care required. Triage is a way of sorting patients who phone the practice or present for care to ensure that patients with the greatest clinical need are prioritised for treatment. It is important to know what constitutes triage, i.e., triage policy, procedures and triage tools, and to retain this as evidence for accreditation purposes. So what is the purpose of triage? Triage helps practices meet patient safety requirements by ensuring that the sickest patients are seen first. Triage provides a structured and consistent approach to seeing patients and alerts the practice team to potential emergencies. If the patient phones ahead, triage allows time for resource allocation and contingency planning. The current pandemic has put a spotlight on triage and the way telephone calls and presentations are screened by reception staff to ensure the safety of staff and other patients attending the practice. Knowing that the patient may have a communicable disease allows the practice to allocate a staff member to triage the patient in their vehicle, provide the patient with a mask, and escort them to an isolated room at the practice for medical review. Having a triage policy in place is also important for risk management. Defined roles and responsibilities for practice staff and clearly articulated triage processes take the guesswork out of prioritising treatment. All documents relating to triage need to be retained by the practice as evidence for accreditation purposes. Triage support tools. It is important that the responsibility for triage is shared by the whole team and that all practice staff, read and understand current RACGP standards in relation to triage. As the first point of contact for triage, it is critical that reception staff are comfortable approaching clinical staff at any time in the triage process and are supported in determining the urgency of patient treatment with open communication channels, effective triage policy, and suitable training. It is not the role of reception staff to make clinical decisions, formulate a diagnosis, or coordinate clinical activities. Triage policy and procedures need to be in place to support frontline staff to use an approved triage tool to prioritise appointments, inform clinical staff, using prompts to do so in each triage category, and redirect patients with urgent needs to the emergency department or to another practice if a timely appointment is not available. Regular triage review meetings, attended by both clinical and non-clinical staff, can provide an important learning opportunity for members of the practice team to openly discuss any incidents or near misses without fear of reprisal. Working together to make changes in the triage policy can be used as a team-building exercise. Core principles of triage include consistent guidelines to assist in prioritising the order in which patients are seen, a well thought out decision support system to elicit the required response from reception staff, key assessment questions to assist in categorising the problem, a robust triage system which allows staff to quickly identify and respond to emergencies. This could mean transferring the call to clinical staff immediately or asking the patient to hang up and call 000. Documentation of triage outcomes may be useful in monitoring and responding to changes in the patient's condition, managing risk, and meeting accreditation requirements. A responsive triage system ensures timely access to care. It is everybody's business to keep patients safe by becoming familiar with current RACGP standards around triage policy and procedural guidelines at your practice for administrative and clinical staff, customised triage guides, for example, pop guns that are easily accessible, and a system for documenting triage responses. So what can your practice do to involve every member of the practice team? Combined training for clinical and reception staff, such as triage training, CPR, managing difficult people, and aggression training. Displaying the triage tool in the reception area. Displaying signs in the reception area with information about time-critical emergencies, and advising patients in the waiting room to let reception staff know if they have a serious medical condition or are experiencing major symptoms. Triage policy with input and agreement from all members of the practice team. Information about telephone triage on the practice's intranet, and icebreakers to get people used to working together as a team. To meet the current RACGP standards for patient triage, all members of the practice team must know how the practice identifies patients with an urgent medical need, how medical emergencies are identified and appointments prioritised, how to seek urgent medical assistance from a clinical team member, and how the practice manages patients with urgent medical needs when the practice is fully booked. Either in-house or external training may be required to enable administrative and clinical staff to identify patients in need of urgent care. Administration staff who are required to access patient health records must also know and comply with the patient confidentiality requirements. So where does triage take place? Reception staff effectively undertake telephone triage whenever a patient phones the practice to book an appointment with a doctor or nurse. Before putting the call on hold, it is important to ask whether the matter is urgent and know which calls to transfer to clinical staff. Telephone triage is also an important way to manage cross-infection by allowing reception staff to identify infection risk before the patient presents and taking steps to reduce exposure of other patients and staff at the practice. Patients presenting at reception with or without an appointment may also require triage. It is not uncommon for patients to require triage following collapse in the waiting room, in practice hallways, and even in the patient toilet. Some patients may feel well enough to drive themselves to the practice, but may collapse in the car park or surrounding area. Patients may also require triage after the consultation. This includes patients under the nurse's supervision who faint after having blood taken or have an adverse reaction following immunisation. Evidence of triage for accreditation purposes extends to on-hold and after-hours messages when the patients phone the practice. The standard messaging being, if this is an emergency, hang up and call 000 immediately. Other evidence may include triage guidelines in the reception area, triage flowcharts available for reception and the clinical team, signage displayed in the waiting area advising patients with high-risk condition or deteriorating systems to let reception staff know, evidence that the waiting list is updated if there is an emergency, and that patients in the waiting room and those yet to attend the practice are informed, as this may increase their waiting time. We have already established the need to ask the caller if the matter is urgent before putting them on hold. It is also important to end calls that do not require immediate care with a disclaimer such as, call back if you get worse. Check your on-hold message to make sure that patients aren't waiting too long to hear the instruction. After-hours messages recorded by practices typically include advice to call 000 for emergencies and may provide contact details for a locum service. Health Direct is widely accepted after-hours primary care service in Australia and New Zealand, and their number may be included in the after-hours message. Reception staff need to understand their non-clinical role in patient triage, and that it involves asking screening questions that are framed in the context of the patient's presenting symptoms and described in the patient's own words. The role of reception staff is to use a triage tool to elicit the required information from the patient and guide them towards a set of actions aimed at delivering optimal care, but stop short of clinical diagnosis and treatment. Reception staff need to become familiar with the types of calls that require transfer to clinical staff and when it is necessary to interrupt the GP or nurse. The purpose of retrieving the patient file is for reception staff to document the triage activity in the patient's record, in addition to clinical notes by the GP or nurse, and possibly send information to the emergency department if requested to do so by clinical staff. Calling 000. Ask patients or others to call. This allows the operator to provide advice while waiting for the ambulance. It provides paramedics with direct update on patient's condition, and it enables more precise directions for the ambulance drivers. Calling on patient's behalf. Ask patients for full current address and location for ambulance dispatch. Ask patient for best contact number and advise them to leave the line free. Ask patient to unlock front door and ask if next of kin need to be notified. Patients sometimes die in waiting rooms while waiting for care to be provided. The practice could display signage in the waiting room advising patients with a high-risk condition or deteriorating symptoms to let reception staff know. It is important to periodically check on the condition of patients in the waiting room and provide them with regular updates on waiting times. There are 6 main steps in the triage process, named the prioritisation of patients, a guide to urgency for non-clinical staff, commonly known as pop guns. Ask screening questions. Is this urgent, or can I put you on hold? Then, to give you the most suitable appointment, is it okay to ask you a few questions? Prioritise according to the urgency of medical need. Category A for chest pain compared to Category F for an eye or ear infection. Provide patient management advice. Is this an emergency? Hang up and call 000. The disclaimer for telephone triage can be, call back if it gets worse. We may need to see you earlier. If the matter is urgent, we will advise you to go straight to your nearest emergency department or to call 000 for an ambulance. Informing clinical staff. Inform the GP or nurse within 30 minutes. Document activity means checking the triage policy and procedures at your practice regarding documentation of triage outcomes in addition to clinical notes by the GP or nurse. If your practice doesn't have a triage policy, you may wish to keep a record and promptly notify clinical staff of all emergency cases triaged by reception staff, anyone you are worried about, anyone likely to call back. Documenting triage policy and procedures provide evidence that the practice has a system in place to ensure timely care for patients who need it most. It includes procedural guidelines for administrative and clinical staff, a triage tool, e.g. Pop Guns resource, that has been tailored to the types of patients seen at the practice, a well thought out triage process with actions to support patient management by non-clinical staff. Triage training should be available for administrative and clinical staff, including in the orientation of new staff and included in refresher training for professional development. Plans to review the triage system suggest that the practice is taking time to evaluate whether the existing triage system is working well, incorporating feedback from reception staff and possibly using practice staff meetings to discuss triage issues using case studies. In the development phase of a triage policy at your practice, the practice team needs to consider patient demographics, the skill mix of practice staff, the different types of services offered by the practice, and where the practice is located. The triage policy required at the Aboriginal Health Service in Whyalla, for example, will be quite different from what is required in the Adelaide Hills or next door to the Port Augusta Hospital. Practices in remote locations may even have an alternate or additional number to call for emergency assistance. Consensus is needed by the practice team regarding roles and responsibilities of each team member involved in patient triage. An existing triage template, such as Pop Guns, can then be customised to suit the needs of the practice team, and the patient seen at the practice. Large practices may have a triage nurse, so this role needs to be included in the triage policy and procedures. The implementation phase includes a practice meeting to plan implementation, ensuring there are triage tools such as pop guns near each telephone, that practice staff have access to CPR and triage training, that sufficient emergency equipment is available and checked daily, that patient information includes signage in the waiting room advising patients to let reception staff know if their condition worsens, and that an implementation date has been set for the triage policy to commence. The review phase requires the practice team to review RACGP standards pertaining to triage, set a date to revise the triage guide, and ensure orientation of new staff, including GPs, to the triage policy and procedures and triage tools at the practice. So who are your most vulnerable patients? And does the practice have the required mix of skills and equipment for these patients? Or is the best care at the nearest ED or at another practice? Always err on the side of caution with infants and children. Bring them in early. Never dismiss parental concerns and interrupt clinical staff if unsure. Babies and young children can dehydrate very quickly if they have been vomiting or have diarrhea. A baby with fewer wet nappies should be seen without delay. The older population is at higher risk of stroke. The FAST acronym is a good one to keep in mind when making these appointments. F. Has their face drooped? A. Can they lift both arms? S. Is their speech slurred? And T. Call 000. Time is critical. Be alert for possible complications when vulnerable patients phone the practice. For example, this could be, but not limited to, patients that have had recent surgery, are pregnant, have chronic disease, undergoing chemotherapy, or are in psychological distress. For patients presenting with COVID-19 or flu-like symptoms, enact and follow your COVID-19 policy, plan, or guidelines. For patients presenting with other suspected infectious disease, including measles or chickenpox, 1. Provide the patient with a surgical mask to be worn before entering the practice and to remain throughout the visit. 2. If the patient has phoned ahead, collect the patient from the car park and escort via a back entrance, if possible, to a secluded area of the practice. 3. Isolate the patient to an area not in common use and fix a laminated sign to the door advising caution, isolation room, do not enter. In regard to personal protective equipment, known as PPE, for clinical staff, 1. Surgical mask, gloves is a minimum PPE requirement. 2. Additional protective eyewear is required for the collection of nose, throat swabs, and if the patient is bleeding, vomiting, or coughing. There are far more clues about a patient's condition when presenting in person compared to calling by phone. Note whether the caller sounds relaxed or is irritable and agitated during the call. Listen carefully, allowing the person to state the problem in their own words, rather than interrupting with screening questions too early. If the person is known to the practice, do they sound unwell or appear different in some way? When the person presents at the reception desk, are they calmly responding to your questions, or do they appear agitated, aggressive, and noisy with jerky physical movements and lots of expletives? Consider body language. Is the patient bent over in pain or walking purposefully to the waiting area? Facial expressions. Is the patient's face contorted with pain or do they appear content or sad, angry or confused? Speech. Is the patient chatting happily on arrival or slurring, talking rapidly or incoherent? Can you smell alcohol on their breath? Skin colour. Is the patient's skin pink and dry, or do they appear flushed, pale, or sweaty? Behaviour. Is the patient hunched over in pain, gesticulating wildly, or acting in a threatening manner, or responding to your screening questions in a calm and orderly way, or volunteering relevant information? Does the infant brought in by a worried mum appear to be unusually quiet, lethargic, or floppy? Communicating with sick people or their carers is often challenging. While it is tempting to interrupt, particularly at peak times, this can be very frustrating for the patient, who may be trying to tell you some critical information, such as, I had some oysters half an hour ago, my tongue is swollen and I can't breathe properly, or I have a dull pain in my chest and my skin feels clammy. Some patients are not good historians, while others go off on tangents that don't appear to be related to the actual problem. Allow the patient some time to tell you why they have called, then try to direct the conversation with a series of direct, closed-end questions. Screening questions such as, can you tell me your name, date of birth, address, and phone number, and asking specific questions about the nature, duration, and severity of the problem is a good way to get them back on track. Use verbal and non-verbal cues from the patient and check in with them from time to make sure they understand what you are saying. Take care to ensure that your questions do not inadvertently trigger aggressive behaviour. Reflective listening is a good way of checking in with the patient that you have understood correctly what they have told you. However, parroting back minute details to the patient may be irritating or interpreted as patronising behaviour by the patient. When ending triage calls, use disclaimers such as, call back if your pain gets worse and we'll try and fit you in earlier. When responding to angry callers, it is important to speak quietly and calmly, particularly if the caller is shouting or sounds agitated. The HEAT acronym may be useful. Hear them without interrupting. Empathise with their situation by acknowledging that they sound upset and possibly worried about what is happening. Apologise without admitting fault for what is happening to them and the effect that the delay, communication, etc. is having on them. Take action. Tell them what you'll do about it. E.g., I'll let the nurse know that you're upset about the long wait, or I can see that you're in pain. The GP will see you soon. Whenever someone calls the practice to book an appointment, it is important for reception staff to ask whether the problem is urgent before putting the call on hold. This may be easy to gauge from the tone of the person's voice or sense of urgency. However, some callers may sound calm despite clearly needing an ambulance. Reception staff need to confirm and record the patient's date of birth, phone number, and address. This is important if the patient collapses while on the phone and you need to call an ambulance on their behalf. Next, ask the patient to describe the problem. A good way to begin is ask, to help me give you the best appointment, is it okay to ask you a few questions? The patient may ask to speak to a nurse or doctor at this stage. Then proceed with questions such as, is this a new or recurrent problem? Is the pain sharp or dull? Is the pain constant or does it come and go? Have you had any recent admissions to hospital or recent surgery? What makes the pain worse? Have you taken anything for the pain? Ask about the duration of the problem. How long have you had this problem? For hours? Days? Weeks? It is important to ask whether the patient has any existing major health problems. If the patient can't name the condition, ask whether they are taking regular medications and if they have any allergies. If unsure or the problem sounds serious, put the call through to a GP or nurse. Reception staff need to understand the complete set of actions required when triaging patients and their role as non-clinical staff in the triage process. Remember, it is not the role of reception staff to diagnose the problem or to provide clinical care. Use a triage tool, such as pop guns, to categorize the problem into one of the 6 categories from A to F. Follow the recommended actions for each category. These are specific instructions given to patients, such as, come to the surgery now. Include a disclaimer at the end, such as, come to the surgery today and call back if it gets worse. You will notice that the timing for informing the GP or nurse varies according to the urgency of the condition. For example, call for help now is unequivocal in category A compared to simply informing the GP or nurse in Category F. Upon retrieving the patient file, 2 additional steps for patients in Category A and Category B include informing the emergency department and providing information to ED staff. This would normally be done in consultation with the GP or nurse. Check the practice's triage policy regarding documentation of triage outcomes. These notes are recorded by the person triaging the patient in addition to clinical notes recorded by the GP or nurse in the patient history. Documentation of triage outcomes is recommended for all emergencies, anyone that you are concerned about, and anyone likely to call back. There are some subtle but important differences between Category A and Category B. Patients in Category A have a condition that is sufficiently life-threatening to require an ambulance and a call for assistance from the GP or nurse immediately. Patients in Category B need to attend the emergency department without delay, and the GP or nurse need to be interrupted immediately to advise them of the situation. It is important to remember that patients assigned to categories of lesser acuity can deteriorate upwards to Category A or B in a matter of minutes. Ending calls with a disclaimer such as "call back if you get worse" provides the patient with specific instructions about what to do if their condition deteriorates. Calls from patients with conditions in Category C should be transferred to the GP or nurse and clinical staff advised immediately if the patient presents in person. Patients calling with conditions in Category D should be advised to attend the clinic immediately for triage by the practice nurse. These patients can be slotted in between appointments or observed in the waiting room and seen at the end of the session. Although the time frame for informing clinical staff in Category E, inform GP or nurse within 30 minutes, is less restrictive compared to Category D in the previous slide, advise GP or nurse now, you will notice that the same disclaimer, call back if it gets worse, follows the 2 actions recommended in Category E and Category F. Take some time to reflect on the triage activities that you are involved in every day at your practice. Here are just a few scenarios that you may be able to relate to. Advising patients to hang up and call 000. Transferring urgent calls to the GP or nurse. Leaving some appointment slots free each day for urgent cases. Updating patients in the waiting room on waiting times, particularly following an emergency, and advising patients waiting at home of delayed appointment times. Arranging a home visit for a patient with the flu, or asking to meet the patient in the car park after donning suitable PPE, providing them with a mask and escorting them through a back entrance to a secluded area of the practice. Emergency calls should end with a disclaimer advising the patient to call back if the problem gets worse and advising them of the likely outcome if that was to occur. Key points in the disclaimer used in this slide are: your symptoms could become worse or change. If that happens, call back to arrange an earlier appointment. If we find that your situation has deteriorated significantly, we may advise you to either go to your nearest emergency department, hang up, and call 000 for an ambulance. So what is the purpose of documentation? Documenting triage outcomes helps to ensure a robust triage system that meets best practice and accreditation standards, is safe for patients and their families to access, and provides staff with medico-legal protection. It is also useful evidence if things go wrong. It is important to document symptoms described by the patient and the triage category assigned, outcomes-specific management advice given to the patient and informing clinical staff, whether staff advised the patient to call 000, whether the emergency department was notified and information sent. Critical documentation includes any deviation from the triage policy and procedures at the practice and why, record in notes section, any follow-up instructions or advice given to the patient or carer, whether the patient refused any recommended actions. Next, we will look at the patient triage contract form developed by Country SAPHN, which can be tailored to reflect triage policy at your practice. We have created a patient's triage contact form. This is a short and easy document you can leave at your reception desk to quickly capture the outcome of the conversation with the patient. This information can be given to clinical staff and scanned into the document section of the patient notes. If you would like to utilise the form within your practice, please feel free to contact Country SAPHN to obtain. Later in the presentation, you will see we have created a PDSA, a Plan, Do, Study Act document for your use in capturing quality improvement in your practice. It is recommended that this two-sided PopGuns triage process resource is tailored to the needs of the practice, including patient demographics, your location, skill mix of clinical staff and non-clinical staff, and the services provided by the practice, for example, respiratory clinic and aged care. Printing advice. Print in colour, two-sided, A4 size, and laminate or use a transparent plastic sleeve. Location. Easily accessible near each phone at the practice and in particular at reception. When enacting your emergency action plan, found on the reverse side of the PopGuns tool, try to remain calm and don't panic. The patient, their family, and/or carers are relying on your ability to keep a cool head. Be aware of and respond to safety needs of the emergency. For example, if it appears that the patient has been electrocuted, instruct the caller to turn off the power if safe to do so. Use a non-conductive tool like wood or cardboard if required, and do not automatically touch the patient until safe to do so to avoid electrocution. Assess which patient needs to take priority using the symptoms described to you. Ask as many questions as required to determine the urgency of treatment required, but be guided by the urgency of the situation. For example, if hang up and call immediately, 000 is indicated. Deal with any injury or illness in order of severity. A middle-aged person vomiting all night who is otherwise healthy would be less urgent than a 6-month-old baby who had been vomiting and crying for the last few hours and suddenly goes quiet and hasn't had a wet nappy for hours. Call 000 for ambulance, police or fire service. Injured people sometimes need more than one service. It is important to check the RACGP standards on the website for any updates and regularly review the triage policy at your practice to ensure it still meets the needs of patients and staff. This might include clinical audits, monitoring, and evaluation of triage outcomes and cause and effects analysis. Feedback from reception staff should be included at regular triage review meetings, providing an opportunity for reception staff to raise any issues around their role and communicate their concerns to clinical staff about challenging triage situations. The triage review meeting allows the whole practice team to have a frank and open discussion about specific incidents and near misses. This allows reception staff to contribute ideas for quality improvement initiatives aimed at improving the triage system and triage processes at the practice. It is prudent for the practice to have effective risk management in place to ensure patient safety and the medico-legal protection for staff who triage patients at the practice. Some effective risk management strategies might include regular triage review meetings with input from reception staff, staff training and the orientation of new staff to ensure that all members of the practice team are A, familiar with the practice triage policy and procedures, and B, understand their role and responsibilities within the triage processes, and C, consistently use triage tools and document triage outcomes for emergency patients attending the practice. I will briefly reflect on the model for improvement, which provides a framework for developing, testing, and implementing changes leading to improvement. The model provides an easily understandable scientific method which acts to moderate the impulse to take immediate action with the wisdom of careful study. 1. What are we trying to accomplish? This is the goal. 2. How will we know that a change is an improvement? This is the measure. And 3. What changes can we test that will result in an improvement? This is the idea. The PDSA cycle is shorthand for testing a change by developing a plan to test the change. Plan. Carrying out the test. Do. Observing and learning from the consequences. Study. And determining what modification should be made to the test. Act. Country SAPHN has prepared a PDSA cycle example in relation to the pop guns and the triage contract form. This is in Word format so that you are able to adapt to your practice needs. Going through this webinar and filling out a PDSA cycle contributes as evidence towards your quality improvement activities, aligning with your quarterly PIP QI incentive payment. If you require further training on PDSA cycles or a copy of the pre-filled document, please contact us at support@countrysapHN.com.au. In closing, we hope that this webinar has given you a better understanding of the triage process and the importance of practice guidelines. The triage policy and procedures at your practice need to be regularly reviewed against the RACGP standards and include clearly defined roles and responsibilities for all clinical and non-clinical staff involved. Staff training needs to be prioritised to ensure that all new staff, including GPs, understand the triage process at orientation and that there are ongoing opportunities for staff development. Structured systems such as the PopGuns triage process ensure consistent decision making, allowing reception staff to quickly identify patients with urgent needs and prioritise the order in which they are seen. Complying with the RACGP standards in this way equates to effective risk management and provides evidence of safe and effective patient triage to meet accreditation requirements. Thank you for your attention. Please feel free to submit any questions about the triage process, use of the PopGuns tool, and documentation of triage outcomes by non-clinical staff to support@countrysapHN.com.au.